I'm Fran. I've been here at Children's for 25 years, 15 of which have been down in the emergency room. I think we have a great lineup here, starting with Dr. Kareem Mansour, who will talk to us today about DKA, non-DKA, hyperglycemia, and anything else that comes to mind.
Well, first, thank you, Fran, for inviting me. I feel very honored to be the first speaker at the inaugural conference, so that's great. For those of you who don't know me, as Fran said, I'm Kareem Mansour. I'm one of the physicians in the emergency department. That's where I live, that's where they keep me, right in the trenches and right where I belong. It's nice to see a lot of familiar faces out there. It kind of takes away from some of the anxiety of being up here, but also some new faces. I see a lot of white coats in the back. Are you students, or nursing students? Yeah. Great, welcome. And I see some very senior nurses out there and some young faces too, so maybe some new nurses, which is great. So, when Fran asked me to kind of send in all my materials and so that you guys would have access to some of my slides and all this kind of stuff before the talk, and I see a lot of handouts up at the front, but I thought I'd do something a little bit different, something a little unorthodox for me too, because I've given a lot of lectures in this institution, and most of the time they're sexy PowerPoint presentations that everybody can sit there and read slides at, but I really think that in this type of setting, in this type of what we're trying to accomplish, more audience participation and interaction and open discussion about some of this stuff actually might be a little bit more useful. So I'm going a little bit outside of my comfort zone, but we're going to just kind of shoot from the hip a little bit. But I am here to talk about sort of diabetic emergencies, both the diabetic ketoacidosis or DKA emergencies and then the non-DKA emergencies. I will start by saying I have nothing to disclose but the fact that I am not an endocrinologist and I am not an intensivist. I am an ER doc. So what that is this is DKA through the eyes of Kareem. Okay? So I thought the way I would start this is we see a lot of diabetes, new onset diagnoses, and known diagnoses who are really sick come into the emergency department. But if I focus a little bit on the new diagnosis patients, you can imagine if you're a parent and you're bringing in your child, and maybe your pediatrician did some lab based on some symptoms that your kid was having, and said, you know what, I'm really worried your kid has diabetes and I want to send you to the ER. You can imagine what that parent might be going through. Maybe they have relatives that have diabetes and they know a little bit about it. Maybe they've heard the word insulin and they know that there are shots involved. Or maybe they know nothing at all about it. And so the dynamic of our teaching institution is a patient comes into the emergency department, they have a chief complaint, they get put into our system, they'll see a resident physician who will take a history, do an exam, and then present to an attending physician, and the attending will hear about it, kind of tailor-make their management plan, and it may be a while before somebody who actually explains what's going on to the family, a long time may go on before that happens. So I thought I would start by saying, I've got this like soapbox speech that I've given 100 times about diabetes, and this is how I explain it to families. And it's about 5 minutes long, so bear with me. So pretend you're a parent, and you're sitting there and your kid's just been diagnosed with diabetes. So the first thing I ask them is, do you know what diabetes is? And sometimes I get some nods and some shrugs, and I say, well, let me tell you. Here you go. Your body is a factory, okay? And in your factory, its sole purpose is to make energy. And that energy is used to drive all the systems in our body so that we can live. Each of those individual cells in our body is a factory. Now, factory needs supplies to make the energy, right? And we give our body that supply when we eat. And those supplies come in the form of sugars, fats, proteins. Everything that we eat gets digested in a certain way so that we can get those supplies into the factories so that they can make energy. Okay? So they pretty much understand that. Sort of simple metabolism. Then I say, okay, so one of the things that's really vital about getting the supplies to where they need to be is something called insulin. So you're hungry. You go to Mickey D's, you get yourself a Big Mac, and you eat your burger. And it sits in your belly, churns up, gets digested, and primarily, one of the main things that gets absorbed is sugar, glucose, carbohydrates. I use those words. They all essentially mean the same thing. Okay? Those sugars get absorbed into your bloodstream. They're circulating in your blood, but they don't know where to go. Remember, the individual factories are those cells. Okay? So then your body says, aha, we got a buttload of glucose circulating in our bloodstream right now. So we got to get it out of the bloodstream and into the tissues and into the cells where it can be utilized to make that energy that we need. And we use something called insulin. So our pancreas is like a little sensor, and it says, oh yeah, our blood sugar is going up. Let's secrete some of that insulin, which tells the body to pull the sugar out of the blood and put it into the cells for energy. Okay? So, let's say for example now, there's something wrong with the pancreas. Maybe it doesn't read the amount of glucose that's circulating in our blood so well. Or maybe it recognizes that there's a lot of sugar around and it's telling the pancreas to make our insulin, but it's just not making it. Or maybe it does make the insulin, but the insulin doesn't work properly. Okay? What happens is there's a lot of sugar just circulating in the blood and it's got nowhere to go. Right? Over time, that's going to start to accumulate. Well, the body doesn't like a whole lot of sugar in the blood for long periods of time. So what happens? Well, if you remember back in like 6th grade chemistry or biology or science, there was something called osmosis, right? And osmosis is the pulling of water to areas of low concentration to high concentration, right? So if you've got a lot of sugar floating around, that's going to act like a sponge and pull water out of the tissues into the vascular system where all the sugar is, okay? So what you do is you increase your intravascular volume. That sounds good, right? Keeps us nice and juicy. You know, that's what we do when we're dehydrated, right? We put in IVs and we give them boluses to increase their intravascular volume. But what happens is that volume goes somewhere eventually, your kidneys. And what does it do? It filters all of that extra volume and you pee it out, right? So what are one of the common early presenting complaints that diabetics have? Polyuria. What does that mean? You pee a lot. You increase your urination, right? And that's because we've increased the amount of volume of fluid that gets filtered by our kidneys, right? So you start to pee a lot. Now the very astute parent or pediatrician will hear that a child is getting up in the middle of the night, or suddenly they started wetting the bed. And my kid's like 9 years old. He hasn't wet the bed since he was 5. You know, red flags. Okay? In addition to polyuria, right? So now you start to urinate more frequently, right? And when you urinate more frequently, you functionally get dehydrated. So what is your body's normal response? You have receptors in your brain that say, oh, I'm a little bit dehydrated. What do I need to do? Drink, right? That's called polydipsia, right? So you increase your thirst. So you have this vicious cycle of polyuria, polydipsia. That's what we hear about. So those are some of the 2 early clinical features of diabetes, right? Then there's this thing called weight loss. We always talk about weight loss, right? Why does that happen? Well, Remember those little factories we talked about? They're still working, and they still need to make their energy, but they're not getting the supply that they need from the meals that you're eating in terms of your carbohydrates, right? You got all this blood sugar circulating around, and it's not getting pushed inside the cells. So what happens next? Your body utilizes what it can to get the substrates it needs to make the energy. And fortunately or unfortunately, there are two other sites that it can use to break down to get those substrates to make energy. And that's fat and muscle, or protein, right? Let's talk about fat. So if metabolism is the production of energy, catabolism is the breakdown of substrates that you need to make energy. So you start to enter a catabolic state. You're breaking yourself down to make energy. And if you break down fat, you get a buttload of energy. In fact, for every unit of fat, you generate 9 kilojoules of energy. For every unit of glucose, you only generate 3.6. So you actually get more bang for your buck if you start to metabolize fat. The body learns this and goes, all right? That's what I want to do. I want to get lean, right? I don't have to work out, right? So you start breaking down your fat. Here's a big problem, right? One of the big byproducts of fat metabolism is ketones. Ketones are acids, okay? So everybody talks about ketosis. We all know that part of our screening in diabetics is we give them these little urine dipsticks and see if they've got ketones in their urine. That is a measure of catabolism, particularly fat catabolism. So if you've got increased ketosis or increased ketones in your blood that start to get filtered in your urine, you know you're in a catabolic state. Whether you're a new diabetic or not, you're in a position where you're going to start breaking yourself down instead of utilizing the substrates that you want. Well, fat metabolism can be good. We already know it produces a tremendous amount of energy. We already know it slims us down because we all want to be slim, right? But what does ketones that start to accumulate in your system cause? Belly pain, nausea, vomiting, headaches, lethargy, right? All of the things that we see when our sick diabetics come in who have DKA, all right? So, you're that parent in the room right now and you're learning about all this and you're kind of filtering all this information and you're saying, okay, so basically what you're saying is my kid isn't making insulin, or the insulin that he's making isn't working properly, and all these acids are building up, and that's why he's losing weight, and that's why he's got that really funny kind of fruity breath to him, because that's what ketones smell like. And I said, yeah, but what we need to do now, right, is we have to find out whether or not it is an insulin-resistant problem, meaning you make insulin, but it's not working properly. Or is he not making it at all? So we do all these blood tests that the endocrinologist asked of us to do and interpret. But until then, we have to supplement them with insulin, okay? And depending on how sick they are, depends on how that insulin gets delivered. So, does everybody kind of understand the basic pathophysiology of diabetes and how over time they can get sick? Any questions? You guys got it. Sam.
So, like when we have these kids come in with in DKA, and if they're all, we check their pH and their pH is always low.
Okay.
Is that because I mean, I always thought it was, in my head, somebody said, well, it's because they have too much lactic acid. I mean, as opposed to what I'm hearing you say is like ketones are an acid. So anyways, the pH change, is that because of lactic acid? Like, I mean, I always thought in my head it was the Krebs cycle, the business of the Krebs cycle, where we had, when you can't get oxygen and sugar the way you want it, then you go through the anaerobic metabolism and you get lactic acid. So I guess my question is when we're here and their pHs, when we come in, their pHs are low, like 7.1 or 7.0. What causes that? Is that ketones? Is that lactic acid? Or
It's a great question, and the answer is it's probably both, okay? Because functionally what you're doing, initially it's going to be all ketoacidosis, and that's sort of the true definition. The pathophysiology is the ketone bodies accumulate. If you measure ketobutyric acid, which is the type of ketone that's made from fat metabolism, it's strikingly elevated in patients who have DKA, okay? But that quickly dissociates into hydrogen ions and ketone bodies, okay, in the blood. But what happens over time is we see kids that spill ketones in their urine all the time. That means they have elevated ketones in their serum, but they're not acidotic just yet, okay? So the body has all these compensatory mechanisms in place to buffer that ketosis that goes on. But eventually, right, that kid gets sicker and sicker. They get more dehydrated. When you're dehydrated, your distal perfusion goes down. When you're not perfusing, you push yourself into anaerobic catabolism of every tissue, muscle, fat, bone, skeletal, smooth, all of it. And that produces a lactic acidosis. There's really no true way to differentiate these, because when you even measure the lactate initially in a kid that comes in, there's so many confounding variables that can cause an increase in your lactate. I mean, if you just get a tourniqueted sample of blood, your lactate's going to go up. And by what value, nobody knows. That's why lactate in sepsis hasn't really panned out the way it has in adults, in pediatrics, okay? So I wouldn't put too much stock into that type of acidosis, but you bring up a really good question. Has anybody ever heard the mnemonic mud piles? You know what that means? Mud piles is a mnemonic for all the different causes of, and here's the real key, an anion gap acidosis, okay? And an anion gap acidosis means there's a significant difference in your anions, in your chemistries, that is your chloride and your bicarb compared to your sodium. Your sodium is positively charged, your chloride and your bicarbs are negatively charged. If there's a wide gap between those two values, you have something called an anion gap. And if you're acidotic at the same time, you have anion gap acidosis. I don't want to get too much into it, but DKA and lactic acidosis are both anion gap acidosis. They have wide separations in those two anions. So, in that situation, how you correct it is very similar, okay? So you don't have to worry too much about how much of my acidosis is a lactic component, how much of it is a keto component, but it is very relevant clinically, right? So if you have a kid who's obtunded, right, because they're not perfusing well, because they're hemodynamically unstable, they're profoundly dehydrated, they're very tachycardic, they're almost borderline hypotensive, right? Then predominantly your management is going to be volume resuscitation, because that patient is very much volume depleted, right? And their acidosis is probably contributed significantly by that volume depletion, right? Whereas, and we were going to get into one of these diabetic emergencies, but there's something called hyperosmolar, hyperglycemic, non-ketotic syndrome. These are these really hyperglycemic patients that have sugars over 1,000, right? and they're very, very obtunded because they're dehydrated, but they're not acidotic. And it's really, really odd. Fortunately, it's rare, more common in adults, but occasionally we get them in the ED. If you've seen them, they're striking because, for a lack of a better way of putting it, these are the kids that die on them, right? And they die because of cerebral edema and aggressive volume resuscitation too soon, right? So there's all these little delicate balances that we have to think about. So, great question, but try not to focus too much on the sort of the pathophys of the acidosis as it is, okay, now that we've established that this patient is acidotic, that they're hyperglycemic, right? What's our approach? And that's a good segue into how we manage these, right? So if we look at the management of DKA, diabetic ketoacidosis, the sick diabetic, there's a lot of things that you have to think about, okay? There's the sort of, the goals of management are multidimensional. The first is volume resuscitation. You have to assume, and assume correctly, that all these kids are dehydrated. The second thing is we have to correct their hyperglycemia, right? Everybody's like, let's get our insulin on board. This kid needs insulin, get him insulin, okay? We have to be very careful about that. The third thing is we have to correct their acidosis, right? We know that the hyperglycemia and the acidosis are linked, but they don't correct in a nice linear fashion all the time. In fact, you can overshoot one without correcting for the other, and you can really put yourself in a precarious position, okay? And then finally, you have to consider all of the electrolyte imbalances that these patients have, and when you replete them, how you replete them, and what you need to look for while you're correcting their abnormalities. So, as I think about this, there's a lot of CPGs out there, clinical practice guidelines, things that help the providers in a very stepwise fashion, almost like a cookbook, how you approach the diabetic patient. So I'm going to talk about a little bit why the order in which we do things and how aggressively we do things kind of interplay in our medical decision making.
Kareem, could I just talk for a minute?
Please, yes, I want people to stop me and ask
Yeah, I
questions.
thought this was interactive.
It is, I know, but you know me, Betsy, I like to talk.
I want to interact with
Please.
you. So the kid that comes in with a huge blood sugar but not acidotic is the one you're going to worry about the most. Is that what you just said?
So,
I'll
I want
ask
you,
again.
I did say that, but I want you to take that with a grain of salt.
Oh.
That is going to be, not a grain of sugar. That is by far the most rarest presentation. Okay, in my career here, I've seen one. I know of 2 cases. Okay, they're more common in adults. They're more common with the old nomenclature, type 2 diabetic, because the thought is that they're not acidotic because they do have some insulin circulating around. It's just not as effective. But over time and during some intercurrent illness, something tips them over where they get a rapid rise in their blood sugar, and they do have some insulin activity, so they don't ever get into a catabolic state where they're producing ketones. Okay? But if you do see them, they tend to have sugars over 1,000, right? And they tend to be obtunded, so they're altered in some way. And you measure their pH and it's like 7.3. If you see that triad, that's when you want to think of, I call it HONK. HONK, hyperosmolar, non-ketotic syndrome or coma. Okay? The pathophysiology behind it is so very misunderstood. There's a lot of theories behind it. But if you do see that kid, that is the kid you do not leave their bedside. You get a physician, you get critical care involved, you get endocrinology involved. Those are the kids that are going to herniate from significant cerebral edema that happens. Yes?
So those are the ones we're seeing that are more teenagers?
So they tend to be teenagers. So if you look at diabetes in general, and particularly the insulin resistant, or insulin insensitive, I should say, there tends to be a bimodal peak in terms of age. We see them at kind of early school age, or kind of classic type 1 diabetic. They stop making insulin, they come in, they're like 6, 7, 8 years old, and they're sort of garden variety diabetic. Then you see these teenagers, right? And their morphology can look like anything. You can get the morbidly obese teen who's the true type 2 diabetic, who ate like crap for their whole life, and they're truly insulin resistant. Or the thin, athletic, bright, healthy teen who got some intercurrent illness that tipped them over the edge. Okay? They've tried to find genetic links for this stuff. Nobody truly knows. In the greater world and outside of our pediatric population, if you're over 65, if you're a known type 2 diabetic and you're morbidly obese, that's the risk profile. In our population, it's not. The one kid that I had was, and Stacy, correct me if I'm wrong, was like 15, 16 years old, slim guy, had a sugar over 1,000, and he was managed in the department as your typical diabetic. And we did not realize how important volume resuscitation in terms of the rate at which you resuscitate these patients, how vital that was for him. We didn't know he was sort of in that category, but the non-acidotic portion of it was, at the time, reassuring when it shouldn't have been. Right? We're like, oh, he's not acidotic. He's got a pH of 7.3. Yeah.
So what's the ideal rate or time frame that we want to?
For volume resuscitation? So the classic teaching is you have maintenance fluids for a 24-hour period, right? Then you have to estimate how much volume you're depleted. You take that whole volume and you want to replace the whole thing over 24 to 48 hours, with 2/3 of that volume being repleted in the first 4 to 6 hours. It gets complicated, very complicated. So we've broken that down and digested it to, this is the way we do it. Almost all diabetics that walk through the door, whether they're acidotic or not, they're going to get a 20 per kilo bolus. Stop, right there, 20 per kilo, right? You look at them, and they look dry. They look hypovolemic. Our natural instinct is to give more volume, right? But we have to understand that in this disease process, they're so hyperosmolar, right? So what I want you to think of is the brain as being one compartment and the rest of the body being the other, right? If you've got all this solute circulating in one compartment and the brain is the other, remember that simple osmosis? Water moves towards the sugar, right? So that water is sucking out, or is being sucked out of the brain. It's being sucked out of the intracranial compartment, right? So they're intracranially dehydrated too, right? But now we push all this fluid into them, right? You dilute your extracranial compartment so there's not a big of gap between the brain and the body, so the fluid starts to move in the other direction. and it starts to go into intracranial compartment. And then your brain starts to swell, okay? Well, if it continues to swell beyond the area that you want to be euvolemic or normal volume, right? Then you're going to start to raise your intracranial pressure, okay? Since we're on it, let's talk about it. Raised intracranial pressure. What does that mean? What does that do? How does that look? Clinically, you're going to get a kid who maybe starts to complain of a headache. Maybe they start puking. Ketones make you puke. Hey, he's got ketosis. But he's still vomiting, or he's vomiting more, right? Then the pressure continues to go up, right? Maybe they get somnolent, right? Maybe they start slurring their speech. They classically will get bulbar symptoms. That's oral motor symptoms, right? They start to have memory loss. They don't remember their name. They don't remember the day. They don't know where they are, right? We talk about constant neuro checks. I'm telling my nurses all the time, neuro check, neuro check, neuro check. Especially when they're getting volume resuscitated, because that's the first thing we do when they walk in the door, right? If the kid's going to change, they're going to change within the first hour of management therapy, usually. The textbooks tell you the first 4 hours. But in my experience, it's very early, right? Pressure still goes up, right? Who knows what Cushing's triad is, right? So, bradycardia. Your heart rate starts to go down. Hypertension. Your blood pressure goes up. Ooh, my blood pressure's up. This is good, right? He was kind of hypovolemic to start with. I was a little bit worried that he had some hemodynamic instability. I gave some fluids. Now my blood pressure's up. Awesome. Irregular breathing. The classic breathing pattern for a ketotic patient is Kussmaul breathing. Kussmaul breathing is rapid, shallow. Okay? If you see that and you're acidotic, you're in trouble. If you have Cushing's triad, you're too late. You don't want to see that triad. We're behind the 8 ball on that one. Okay? But you have to be aware of it. You got to pick up on the subtle central nervous system signs early to intervene.
So it's still the standard of care to give a 20 per kilo bolus, even though, so it outweighs the risk of this cerebral edema.
Most of these kids that come in who have pHs of less than 7.3, right? So you're acidotic. Let's forget about our non-acidotic or non-ketotic patient for a while now. Because even our garden variety diabetic in DKA is at risk for cerebral edema. If you have acidosis of less than 7.3, you are at a minimum 10% dehydrated. So if you give a 20 per kilo bolus to somebody who's at a minimum 10% dehydration, you're probably not going to cause the fluid shifts that are going to create clinically significant cerebral edema. If you ask any endocrinologist out there or any intensivist out there, every diabetic that comes in that gets volume is going to have some degree of cerebral edema. It's just a fact, right? The key is it clinically significant, right? So you have to have huge volume shifts, right? Which is why we're very particular about the amount of volume that they get, right? We don't want to give 2 20 per kilo boluses and keep flooding them because of that risk, right? But we do know that somebody who's clinically dehydrated, who gets 1 20 per kilo bolus, isn't going to die of dehydration, right? So we are underhydrating them. Remember, the goal is to hydrate them over a 48-hour period. So if I'm going to give you like a global term, the management of DKA is slow, right? You don't want to be aggressive. For example, in the ED, we're on the receiving end of these patients a lot from other facilities. Well, this is one particular disease process where the management of it is strikingly different in pediatrics than it is in adults. Okay? Very common in the adult world. They get somebody who comes in with DKA, they slam in a bolus of insulin, and then they discharge them. Right? But the insulin bolus in an adult patient is very different than an insulin bolus in a pediatric patient. The reason is the adult patient is not naive to insulin, right? They are going to be able to withstand the rapid push of insulin very, very quickly, okay? Whereas a pediatric patient is usually naive, and one of two things is going to happen. One, either you're going to get a rapid drop in their serum glucose concentration, it's going to plummet quickly, and they're going to seize. Okay, yeah?
Are you referring to the adult type 2 diabetic or the adult type 1 diabetic?
Either.
Either.
Because even the adult type 1 diabetic has been exposed to endogenous insulin long enough to recognize it. It's usually the adult type 1 is due to prolonged insensitivity to the insulin, and now it just doesn't work anymore.
Or like a type 1 that was like diagnosed as a child. Like, do you see the same DKA cerebral?
No, because their ability to respond to the insulin, so you get a kid who's a diabetic, who's diagnosed as a type 1, who goes years on sub-Q insulin, who then comes in DKA. If you push the insulin on them, they've been exposed to, medicinal insulin their whole life. They're probably not going to get the same effect as if you get a new diagnosis kid. But more importantly, the second reason is, and I don't understand the pathophysiology, but it's well documented in the literature, it causes cardiac arrest. So we don't do it, right? And so I am on the phone every day with transferring centers when they tell me they've got this diabetic kid, and I'm like, do not bolus him. And they'll ask me, hey, do you want me to just give him a slug of insulin before I put him in the rig? You out of your mind? No. So, it's an important feature in pediatrics that differs from the adult world, because it is the standard of care with our adult colleagues, not in pediatrics. Yeah.
So a couple things. Back to, can you talk about like measuring serum osmolality, like, and when we do like when we're going to fluid resuscitate these kids and we're worried about cerebral edema, blah 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 blah. Years and years ago, when I did adult ICU, we did serum osmolality all the time. We were checking, and I don't see us doing much of it.
Mm-hmm.
And then the other thing is I want to ask you about is I'd heard that so when we're reducing when we have these kids that are hyperglycemic at like at 800, 700, I was always taught like you never want to drop them less than 200. Like you want to get them, you want to start lowering your sugar, and then your target is 200, and then you stop and you keep them at 200 for a while. And I never knew why.
Okay.
So talk about that if you could.
So there's two questions there. I'll answer the first one because it's in the honk category.
Yeah.
And then I'll try and be brief about it. But I brought my med student notes because it was something that is belabored a lot when you're learning about this stuff. We don't utilize it as much in pediatric practice, but in the adult world, because you said at adult ICUs, they do. Why? Because honk is more common in adults than it is in pediatrics. But remember, the big feature about the honk diagnosis is they are hyperosmolar. And what Sam is referring to is calculating what your serum osmolality is. don't want to get into too much of the chemistry, but a serum osmolality is for how much unit of solute you have per unit of volume. And in this particular case, our solute is our sugar, and our